Welcome to Eye Contact. I'm Massimo Busin. Cataract surgery in an eye with a diseased cornea confronts the surgeon with many challenges. And I'm here to discuss this with Jesper Hjortdal. The first question that comes spontaneous is, how do you examine the cataract if the cornea is not clear?
Well, it can be difficult. So the patients that show up, they will of course have some sort of corneal disease, and then we have to assess whether it is necessary to do a cataract extraction in order to improve the vision of the patient. So assessing the degree of cataract can be difficult in these patients if you simply cannot look through the cornea the way you are used to. Of course, if you have a white cataract, that's obvious. If you also have a quite severe nuclear cataract, yellow, brown, you have a good idea as well. When it comes to milder types of cataract, it can be difficult. You can, usually you dilate the pupil, you use your slit lamp and spend some time in trying to assess the cataract and try to reach a conclusion. If you feel rather confident that there is a visually significant cataract, then you can consider to do a triple procedure where you operate the cornea and you do something to the cataract at the same time. If you are in doubt, it may be better just to go for the cornea as a first step, and then after you have a clear cornea, then you can do a better assessment of the cataract and actually evaluate if it is necessary.
But is there any specific criterion that you use for deciding whether you're going to do DALC, DSEC, or DMEC alone or in combination with the cataract? What leads your course of action?
So it is mainly, of course, it is the visual acuity of the patient in combination with your objective findings. The degree of opaqueness of the cornea, and again, the sort of objective or semi-objective assessment of the lens. In these patients, it can be difficult also to evaluate the retina. Can there be a macular dysfunction? Age-related macular degeneration, for example, or other things. Sometimes it's actually possible to do an OCT of the retina, and that can give you a clue. Maybe also you can get a sort of an idea about the opacity in the lens using your OCT. But otherwise, when it then comes to the cornea, what type of surgery you want to do there, it of course depends upon the diagnosis. Is it a corneal scar, but with preserved endothelial function? Do you have some types of dystrophies, stromal epithelial dystrophies, where you have quite a lot of opacities in your cornea, but you actually think the endothelium is okay? So these cases you would consider doing a DALC, if we say in combination with cataract surgery. Other times you have a opaque cornea from scouring, or and also an edematous cornea, where you can see that, or every indication is that you have failure of the stroma, you have failure of the endothelium, and that would be a PK to go for. And finally, the types of surgery we do at most, that's at least in Europe, transplantation for Fuchs endothelial dystrophy. You have a pretty normal stroma unless the disease has progressed too far, and you will go for DSEC or DMEC in combination with cataract in these patients.
Specifically talking about Fuchs dystrophy, is there any criterion that makes you decide whether you do the procedure of the corneal procedure alone, the cataract alone, in combination, and eventually if you decide for a two-stage procedure, what do you do first?
And it's 100 billion question if I had the answer, because I think we all, many times when patients are referred with Fuchs endothelial dystrophy, 70-year-old patient, and also some cataract, visual acuity 0.5. What to do in this patient? Should we just try to do the cataract and see what happens? Or would you go for a combined procedure? So typically you try to evaluate, of course, the disease severity in the cornea. You can measure corneal thickness. If you have significant edema, and what is significant edema? I mean, in our opinion, with the way we measure corneal thickness, if it is more than 0.6 millimeters or something like that, then there's some corneal decompensation, at least to a certain degree, and also just the presence of the guttae in endothelial dystrophy can significantly disturb visual acuity and contrast acuity and color vision and so on. So the majority of cases with Fuchs and a lens, we will do a combined procedure, even if there's not too much cataract in a 70-year-old person. Sometimes then we say, maybe we are doing too many combined procedures, too many grafts in these patients. Then we talk to the patient, explain you have a sort of weak cornea. There may be a risk that you will actually need a corneal transplantation, DSEK-DMEK. Afterwards, we will take some time between operating the two eyes to make sure the first eye will be as good as it can, or at least that the patient is satisfied before we go to the second eye. And if not, we will typically wait like 2 months, 3 months to see if the cornea clears up, and if not, do the posterior lamellar keratoplasty.
Do you believe that in eyes with central guttata, which is the most frequent form, the peripheral endothelial cell count can help you directing the decision?
It should. It should. I think we try to take a look on the peripheral corner as well to see, I mean, how far does the guttae actually go out. Getting with the instrument we have for the specular microscope we have, it's not so easy to get peripheral endothelial cell count. So one also guideline in our assessment doing a triple procedure or not would be, can you actually, using automated specular microscopy, can you actually see some endothelial cells? And if not, we will go for the triple procedure.
Finally, what about IOL calculation when you perform combined procedures?
Yeah. So it's a good question, because we normally say, oh, these posterior lamellar procedures, they do not influence the refractive power of the cornea, but they do. DSEK at most. We did a study a few years ago where we measured corneal anterior power before surgery and also after. So there is actually a tiny flattening of the cornea, 0.5 diopters, after a DSEK procedure, and probably also after a DMEK procedure, maybe due to a resolution of a slight epithelial edema. For the DSEK, you in addition have typically the graft you put in is a little thicker in the periphery compared to the center, so you will have an additional negative lens effect there. So usually when we do a triple procedure, we aim a little more than 1 diopter more to the myopic side when we do the triple procedure than we would have if it was a normal cataract. For DMEK, it's probably only 0.5 diopter, so more myopia.
Thank you, Jesper, and thank you for joining us. For more information, please visit us at eurotimes.org.